So I'm going to be speaking to you about multimorbidities and how they vary across the most and least deprived areas in England and Wales. I'm drawing heavily on a paper that Gundinis and I published last year on this topic. So Gundi ran these analyses, and I thank her for doing that. I'll just go through what I'm going to talk about. So I'm going to sort of tell you about multimorbidity and why it's interesting, and then do really a description of how it varies by IMD in the Understanding Society dataset. So we're interested in multimorbidities. In 2020, Chris Whitty published an editorial in the BMJ suggesting that multimorbidities are kind of a challenge for us. Multimorbidities are basically having more than one long-term condition, and that's important because the prevalence of it is increasing as the population is increasing. We have people who might be diagnosed with more than one condition. And that's important for health services because mostly health services are organized by condition. So you might have a cardiovascular condition, you might have a mental health condition, but they're not going to be treated by the same people. And that matters because we need to understand kind of the implications of this kind of having more than one condition or having lots of conditions for health services and costs and various other things. But over time, if you're going to have if you're interested in having more than one condition, there are kind of secular changes that are happening in population health. That means that we're not just really interested in older people, that there's an increasing prevalence of poor mental health in younger people. And if we're going to organize services so that we are interested in more than one condition, we need to be understanding what's happening across the entire age range. And a lot of this research has been focused on older people for reasonable reasons, but there's sort of implications for what we're going to do next. The issue for this field, which is relatively new, is that there isn't a consistent definition of multimorbidity. It varies. Lots of people use just having more than one condition, but there are other ways of calculating what we're kind of looking at. So we know that multimorbidity is patterned by socioeconomic position. A paper was published very recently that did a systematic review of the kind of social patterning of multimorbidity, and they suggested that the kind of most consistent measure of deprivation, socioeconomic position that's associated with multimorbidity is the IMD, the Index of Multiple Deprivation, which is a sort of an area level measure of relative deprivation. And so that's quite interesting because the IMD, which we are making available in Understanding Society, is actually composed over a number of subunits. So what we were quite interested in thinking about was what is it about the IMD that we see a patterning of multimorbidity by it, because there are lots of different subcomponents. And the other kind of area of interest for us was whether these area level associations of multimorbidity and deprivation are sort of area level effects, or how much of it is explained by individual level factors. It's sort of analysis that you can do with Understanding Society that you sometimes can't do with other types of data sets. So our aims are to describe the association of multimorbidity and IMD in Understanding Society, and to unpack that association by trying to understand whether the different components of IMD are differentially associated with the domains of it. So I'll talk about all of those different domains in a second. And then to understand which features of multimorbidity are important. So as I mentioned, there's this sort of secular change in mental health, and so we're interested to know whether that sort of secular change in mental health meant that you sort of see different patterns with physical or mental health conditions. So we're doing this work in understanding society. And Luke just talked about understanding society as well. And I'll just do a very quick overview for those of you who don't know understanding society of what the data set is. So the data set, we started collecting data in 2009. It builds on, it's a household panel study, and it builds on the British Household Panel Survey, which began in 1991. We collect lots of different types of information. So here today we're talking about health, but it's a very broad-based data set. It collects information on lots of different things, and the key kind of aims of understanding society and the data that we make available is to sort of understand how individuals and households respond to policies and changes, and sort of these changes that happen over time. And so there's a lot you can actually do with the data set. And one of the things we're interested in, and sort of Luke ended his presentation with, was talking about, you know, how we can do measures with things that change over time and across the life course, and the role of kind of household context and sort of family and household effects on various things. And the sort of point of the panel part of the survey is to sort of understand how things change with kind of when there are policy changes and kind of sort of changes in sort of social circumstances. So there's really a lot of research possibilities with the data set. And I'm sure we'll talk about this later, but the sort of the things that the presentations will generate lots of questions in terms of what can be done next. So we're using, this year we're going to be depositing wave 13 of the Understanding Society dataset. We're using data from wave 10. So the end of wave 10 sort of moved into the pandemic a little bit. So we're using data from 2018 and 2019 here to do these analyses. And I'm presenting data from everybody in the household age 16 and over. And because IMD, the way that it's created is a little bit devolved, and weights can vary by country. I'm using data from just over 28,500 people living in England and Wales. And we're using the data to create this multimorbidity with the questionnaire information. So we asked our participants, has a doctor ever told you? And there's a list of 35 conditions, and we're using that information to try and understand what multimorbidity looks like in the data set. So we did a lot of work because there isn't a sort of fixed way of calculating multimorbidity. So we sort of did quite a lot of different sort of digging around in the data to try and work out which is the best way. So the usual way is just if you've got more than one condition, you are multimorbid. So that's one of the indicators that we used. So if somebody said that they had, a doctor had told them they had a condition and they reported more than one. And then because we're interested in the difference between multimorbid physical conditions and mental conditions, we split that out into those kind of components. And then we did a sort of a kind of cluster analysis of the 35 conditions, and we kind of grouped the conditions into 9 broader groups and then scored that. So there's a number of different ways that you can look at multimorbidity in the data set. This is just a list of all of those conditions. I think I said 35, but there's actually 37 because there's sort of other things in the the physical and mental conditions here. As you can see, we actually collected much more information about physical conditions than mental conditions. And I'm going to talk a little bit more about what we did with mental conditions a little bit later on. But sort of this is the sort of what the data looks like and the sorts of information that we collected from the participants. So, as I said, we're making IMD available in the data set. So what is IMD? It's a measure of the relative, it's an area level measure of the relative disadvantage. And there's sort of 7 domains within it. So there's income deprivation, employment deprivation, education skills and training deprivation. And the thing that we're quite interested in is that there is a health component within IMD. And so there's a sort of potential for sort of tautology here in that we're looking at health conditions and we've got this area level measure of health within the IMD. There are other elements that are created, so crime, barrier to housing, services and living environment. And sort of just give an example of what's, health is made up of kind of an account of anxiety or the kind of years of life expectancy lost due to illness. So those are the kind of things that make up the component for the health deprivation. Living environment includes things like kind of household crowding or distance to amenities. So there's lots of different things that make up what goes into it. We're using the deciles of the 2019 IMD here. So the lower the decile, the higher the relative kind of domain deprivation in the neighbourhood. And we're using data just at the bottom of there. I'm telling you about how there's lots of words in this slide, but sort of the area level deprivation is available at the LSOA level. So that's about 1,500 people or 600 households in kind of each area. So what did we see? So here you can see that, here you can see that however, in practice, really, however we defined multimorbidity, we actually ended up with about 24% of people reporting more than one condition. So 76% of the participants didn't have multimorbidity. They report no condition. So on average, we've got participants reporting less than one condition. So 76% of the participants report no condition or one condition. Of the participants, the 24% of participants who do report multimorbidity, 3/4 of them are reporting more than one physical condition. Only 1% of the participants are reporting more than one mental health condition, and then 5% of a sort of a mixed condition profile. We think there might be an underreporting of mental health, and I'll talk about what we did about that a little bit later on. But just to be aware that is something we need to think about with these data a little bit. So here, this is what our multimorbidity looks like with by a decile of IMD. And you can see that IMD is associated with multimorbidity. So the most deprived areas have a higher proportion of participants reporting multimorbidity. So in the most deprived area, in this top panel, we can see, well, in both panels, we've got the whole IMD there. The 30% of participants are reporting multimorbidity, and it's down to 20% in the least deprived areas. But it isn't all of the domains. So we see an association with perhaps inevitably with the health and disability domain. We also see it with the employment domain and the income domain, and more mixed patterns with the other domains that make up the IMD, the overall IMD. So this is just a sort of description of kind of proportions by each of the IMD deciles here. In a sort of multivariate regression analysis where we're taking into account the individual characteristics of participants, so we're dealing with age and sex and ethnicity, and their NSSEC, so their occupation, we kind of adjusted for individual level participant occupations, and which included the kind of employment status, so whether people are employed, retired, or economically active. What we can see is that in the adjusted analysis, the IMD is still associated with multimorbidity, and it's doing that. I'm just going to slow down because my computer is telling me my internet isn't working so well, but I'll just repeat what I said. So here we can see that kind of however we calculate. So here we're showing you that because we saw similar patterns with however we scored the IMD, this is just that scoring more than one, reporting more than one condition versus reporting no condition or one condition only, that IMD is associated with multimorbidity independently of that, of the individual characteristics, and it's apparent for whether you're reporting physical conditions only or mixed conditions. There was a small proportion of participants who reported mental health conditions only, and so we looked at that in a different way, and I'll show you a little bit about that in a second. But that independently of individual conditions, area level associations are apparent, so that you can see that IMD is associated with these multimorbidity measures, and that the health and disability domains, income domains, employment domains, and education domain are associated there. And actually in the adjusted analyses, the crime domain became significant in here. So we think there's a little bit of underreporting with the mental health conditions. So what we did was have a look at our symptom reporting. So we looked at the general health questionnaire, and we looked at participants. We used the participants who were reporting high levels over the screening clinical cut point for the general health questionnaire to understand if there was something missing when we're using a question which is, has a doctor ever told you you've been diagnosed with a mental health condition, and look to see if how that was what was happening there with IMD and this reporting. And what we see is that for those people who are scoring high on the GHQ, that there's an association of IMD with not reporting that a doctor's told you you've got a doctor told you've got a mental health condition. So here we've got people who are scoring highly for psychological distress, but as you kind of go down the deciles for the IMD, so area neighbourhood deprivation is associated with not reporting a diagnosis, and we think that's quite interesting, and it's not just about what's kind of happening now. So we look back at an earlier wave of understanding society to look at people who are reporting persistently high scores on the GHQ, and it's still apparent there. So it's sort of suggesting that there are people who are living, as it were, with psychological distress, who are not perhaps not using health services, or for whatever reason. And I think that's something that we will go on to unpack. And it's quite interesting, because I think it needs a bit of work in sort of thinking about what's happening there. So what we are kind of concluding is that multimorbidity does vary with the different subdomains of the IMD. Our strongest associations are with health and education and income. In fact, we think our strongest association is not within the health subdomain, but with the income domain. And this was particularly true for physical multimorbidity. And although our mental health multimorbidity in the way that we calculated didn't vary by IMD, we think that's because we've got a bit of underreporting. And in fact, we need to do a bit more work on what's happening with psychological distress in our data set, because that is varying by IMD. And it sort of suggests there's a sort of substantial kind of clinical iceberg of poor mental health in deprived neighbourhoods that we need to do a little bit of additional work on unpacking. So we think that certainly physical multimorbidity represents a substantial population burden in the most deprived areas of England and Wales. And what we found was that this kind of undiagnosed mental health multimorbidity, it might be representing a public health priority in the future. We sort of saw an age difference in those in that story, in that we could see quite a lot a lot of what was happening with the mental health multimorbidity was apparent in our sort of younger participants and in our older participants, which I didn't sort of unpack here, didn't talk about too much here, but we think that it's something that will need to be thought about as we move forward. And there's obviously a lot of work and a lot of questions that this work is arising from this work. So I think there's a sort of this kind of cohort period effect that might become apparent. So as time goes on and as we collect more and more data, we'll perhaps see this sort of the implications of this secular rise in greater mental health difficulties in younger age groups as they're kind of coming through the data set. We would like to do some more work on the concordance of this self-reported conditions with health records. We haven't done that yet, and that's something that we could do in the future in sort of thinking about whether people are just not reporting their mental health conditions, or they're just not going and getting help for their mental health conditions. And then obviously there's lots of work to do on people being selected in and out of areas of deprivation. So and that's there's a longitudinal piece of work that we could do there. So that's it for now. So just to say that ESRC is a key ESRC resource, the Understanding Society dataset, and we're funded by a number of different government departments. And as I said, this work is the work I just told you about is heavily drawn from a paper that we published last year, and there's the reference there if you want to go and have a look at that.